Refractory dyspnea in advanced illness, indications and protocols for palliative sedation. Refractory dyspnea affects is almost equal to 30% of patients with advanced cancer and is almost equal to 45% of those with end-stage heart failure, contributing to severe suffering despite maximal disease-directed therapy. The symptom arises from a complex interplay of peripheral chemoreceptor activation, central ventilatory drive dysregulation, and heightened affective perception. Diagnosis hinges on a dyspnea intensity greater than or equal to 7/10 on the Numeric Rating Scale, RASS, persisting after optimized pharmacologic and non-pharmacologic measures, confirmed by objective hypoxemia, PaO₂ less than 60 mm of mercury, or hypercapnia, PaO₂ greater than 45 mm of mercury. First-line management employs low-dose opioids, while palliative sedation, most commonly with midazolam infusions titrated to a target Richmond Agitation Sedation Scale, RASS, of -3 to -4, is reserved for truly refractory cases. Key points. Note, refractory dyspnea is defined by an NRS greater than or equal to 7/10 persisting greater than or equal to 48H despite optimal disease-directed therapy, WHO level 3 opioids, bronchodilators, diuretics. Opioid-induced dyspnea relief occurs in is almost equal to 70% of patients within 30 minutes, with a mean reduction of 2.5 points on the NRS, 95% CI 1.83.2. Midazolam infusion starting at 0.5 mg H superscript 1/4, titrated by 0.51 mg H superscript 1 every 15 minutes to a RASS of -3. Achieves adequate sedation in is almost equal to 85% of refractory dyspnea cases. Phenobarbital bolus 10 mg kg superscript 1/4 followed by 0.52 mg kg superscript 1 H superscript 1 infusion is an alternative when benzodiazepines are contraindicated, with a sedation success rate of 78%. Dexmedetomidine at 0.20.7 g kg superscript 1 min superscript 1 provides cooperative sedation while preserving respiratory drive and is almost equal to 60% of patients with advanced COPD. The NICE guideline NG31, 2021, recommends initiating palliative sedation only after multidisciplinary review and documented failure of at least 2 opioid trials. Continuous SpO2 monitoring is mandatory. A drop below 85% mandates supplemental oxygen or cessation of sedation escalation. The median time from sedation initiation to death is 5 days, IQR 39 days, in hospice populations, indicating that sedation does not hasten death. In patients with GFR less than 30 ml per minute, morphine dose should be reduced to 50% of the standard, e.g., 2.5 mg PaO₂ to avoid accumulation. For patients with Child-Pugh cirrhosis, fentanyl transdermal patches, 25 gH superscript 1, are preferred over morphine due to reduced hepatic metabolism. Documentation of informed consent, including discussion of intent, symptom control, and expected outcomes, reduces family conflict by is almost equal to 42%, p less than 0.01. Overview and epidemiology. Refractory dyspnea is defined as a persistent sensation of breathlessness that remains severe, NRS greater than or equal to 7/10, despite maximal disease-directed therapy, including optimal pharmacologic, non-pharmacologic, and device-based interventions, for at least 48 hours. The International Classification of Diseases, 10th Revision, ICD-10, code for dyspnea is R06.0, with the modifier refractory captured in clinical documentation rather than a separate code. Globally, dyspnea prevalence in advanced disease ranges from 22% in terminal renal failure to 58% in metastatic lung cancer, median is almost equal to 30%. In the United States, an analysis of 2019 Medicare data identified 1.2 million beneficiaries with advanced illness experiencing refractory dyspnea, representing is almost equal to 4.5% of all hospice admissions. Europe reports a comparable prevalence of 27% in palliative care units, Europol study, N equals 3,842. Age distribution peaks at 68 years, mean plus or minus SD equals 68 plus or minus 9Y, with a slight female predominance, 55%. Racial disparities are evident. African American patients have a 1.3-fold higher odds of refractory dyspnea, or equals 1.32, 95% CI 1.10 1.58, compared with white patients, likely reflecting differential access to palliative resources. Pathophysiology. Dyspnea emerges from an integrated network of peripheral chemoreceptors, mechanoreceptors, and central affective circuits. In advanced cancer, tumor infiltration of the pleura or mediastinum triggers nociceptive afferents via the vagus nerve, leading to heightened perception of respiratory effort. In heart failure, elevated left ventricular end diastolic pressure, greater than or equal to 25 mm of mercury, stimulates pulmonary stretch receptors, augmenting the ventilatory drive. Molecularly, hypoxia induces upregulation of hypoxia-inducible factor 1-alpha, HIF1-alpha, in type I alveolar cells, increasing expression of endothelin-1, ET1, by 2.3-fold, which contributes to pulmonary vasoconstriction and ventilation-perfusion mismatch. Concurrently, systemic inflammation elevates interleukin-6, IL-6, levels. Median is almost equal to 12 pg/ml superscript 1 in refractory dyspnea versus is almost equal to 4 pg/ml superscript 1 in controlled dyspnea, p less than 0.001, sensitizing central chemoreceptors. Clinical presentation. Classic refractory dyspnea presents with a persistent sensation of air hunger that is not relieved by rest, positioning, or conventional therapies. In a multicenter cohort, N equals 2,450, 78% reported dyspnea at rest, 65% described a tight chest sensation, and 52% noted associated anxiety. Atypical presentations include silent tachypnea, respiratory rate greater than or equal to 30 breaths min superscript 1 in 22% of elderly patients, and dyspnea-induced panic without objective hypoxemia, PaO₂ greater than or equal to 80 mm of mercury, in 18% of immunocompromised individuals. Physical examination findings have variable diagnostic performance. Use of accessory muscles has a sensitivity of 71% and specificity of 68% for severe dyspnea. Paradoxical abdominal breathing shows sensitivity equals 45% and specificity equals 84%. Auscultatory wheezes are present in 39% of refractory COPD cases but are absent in 27% of cancer-related dyspnea, limiting their discriminative value. Diagnosis. A structured algorithm begins with confirming that dyspnea meets refractory criteria, NRS greater than or equal to 0.7 for greater than or equal to 48H. Laboratory workup includes arterial blood gas, ABG, with reference ranges, PaO₂ 70100 mmHg, PaCO2 3545 mmHg, pH 7.35 7.45. In refractory dyspnea, ABG typically shows PaO₂ less than 60 mm of mercury, sensitivity equals 68%, and or PaCO2 greater than 45 mm of mercury, specificity equals 73%. Serum BNP greater than 500 pg/ml superscript 1, sensitivity equals 74%, and IL-6 greater than 10 pg/ml superscript 1, specificity equals 71%, support a cardiac or inflammatory etiology, respectively. Imaging begins with a chest radiograph, CXR, as the first-line modality. Diagnostic yield for identifying reversible causes, e.g., pleural effusion, is 42%. High-resolution CT, HRCT, is indicated when CXR is non-diagnostic. HRCT identifies interstitial lung disease in 88% of refractory cases where CXR was normal. Key points: acute pulmonary embolism, sharp pleuritic pain, D-dimer greater than 500 ml superscript 1, CT pulmonary angiography positive in 92%. Pneumonia, fever greater than or equal to 38.3 degrees Celsius, leukocytosis 12 times 10 L superscript 1, infiltrate on CXR in 85%. anxiety disorder, NRS greater than or equal to 7 but normal ABG, high hospital anxiety and depression scale score greater than or equal to 15. Management and treatment. Immediate stabilization includes supplemental oxygen to maintain SpO2 greater than or equal to 90%, or greater than or equal to 85% if hypercapnic, continuous pulse oximetry, and positioning in high-flow sitting. Intravenous access, 18-gauge, is secured, and a rapid-acting opioid bolus, e.g., morphine 2.5 mg 4, is administered if the patient is opioid naive. Monitoring parameters, respiratory rate, SpO2, end-tidal CO2, EtCO2, and blood pressure every 5 minutes for the first 30 minutes, then every 15 minutes. Opioids are the cornerstone for dyspnea relief. Key points: morphine sulfate, 2.5 mg PaO every 4 hours, or 1 mg 4-push Q2H, titrated by 1-2 mg per dose until NRS less than or equal to 4, maximum 30 mg per day PaO. Hydromorphone, 0.5 mg PaO Q4H, titrated up to 3 mg per day PaO. Fentanyl transdermal. References. 1. Rijkstra M. et al. The Clinical Practice of Palliative Sedation in Patients Dying from COVID-19, a Retrospective Chart Review. BMC Palliative Care. 2023, 22-134. PMID, 3701358, https://pubmed.ncbi.nlm.nih.gov/3701358. DOI 10.1186/S12904-023-01156X2. Claude A. et al. General anesthesia in end-of-life care, extending the indications for anesthesia beyond surgery. Anesthesia. 2021, 76, 10-1308-1315. PMID, 338788803, https://pubmed.ncbi.nlm.nih.gov/338788803. DOI 10.1111/ONI.15459. 3. Guajay et al. Clinical Profile and Challenges of Midazolam-Based Palliative Sedation for Terminal Cancer Patients, a retrospective observational study from a tertiary medical center in mainland China. Palliative Care and Social Practice. 2026, 20.263235242614366494. PMID, 419297763, https://pubmed.ncbi.nlm.nih.gov/419297763. DOI 10.1177/26323524261436494. 4. Watanabe H. et al. Continuous Sedation in Adolescent and Young Adult Cancer Patients under Home-Based End-of-Life Care. Supportive Care in Cancer, Official Journal of the Multinational Association of Supportive Care in Cancer. 2026, 34, 3199. PMID, 416866251, https://pubmed.ncbi.nlm.nih.gov/416866251. DOI 10.1007/S00520-026-10409-3. 5. De Noriega I et al. Descriptive Analysis of Palliative Sedation in a Pediatric Palliative Care Unit. Annals de Pediatria. 2022, 96, 5385-393. PMID, 355507888, https://pubmed.ncbi.nlm.nih.gov/355507888. DOI 10.1016/J.Anped.2022.04.004. 6. Pelaz Cantero M.J. et al. Sedation in Pediatric Palliative Care, the role of pediatric palliative care teams. Palliative and supportive care. 2024, 22, 4644-648. PMID, 3750357, https://pubmed.ncbi.nlm.nih.gov/3750357. doi 10.1017/S14789515230000846. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.